I'm Matt Wasserman. I'm in practice in Katy, Texas, a suburb of Houston. Thank you, Brent and Innovasis, for having us out here again this year. I won't take too long. This is not a real complicated topic, I don't think. I've been charged with talking about autograft and its use in spinal fusions today, and we'll kind of compare that to the allograft and other graft materials we've just heard about. Let's see, what button do I, there we go. So let's talk about the types of autograft that we can use, the pros and cons of autograft. I'll talk a little bit about how my practice has evolved, and then we can get into the questions and comments. So autograft can be taken locally through the same incision as the fusion. Posteriorly, that's often the laminar bone that's done in the decompression, and spinous process bone taken in long fusions when a decompression may not be performed. Anteriorly, we can use the anterior lip of the vertebral body osteophytes that is taken down. Most of us take those down and sort of discard them, but that can actually be used as autograft. And then, of course, corpectomy bone in the setting of trauma or degenerative conditions. And then bone marrow can be harvested through the iliac crest or vertebral body with a jam-sheeted needle. From a separate incision, really we're talking about the posterior iliac crest or the anterior iliac crest for anterior surgeries. Often these separate incisions create a little bit of morbidity and post-operative complications, so it's one of the cons to its use. Here's a picture showing what can be harvested from the posterior iliac crest. It's really the workhorse of autograft. You can get cancellous bone, cortical bone, tricortical struts. So what are the pros of using autograft? Well, it's probably nature's best autograft, the oldie but a goodie. It includes both osteoinductive, osteoconductive, and osteogenic properties, live cells, growth factors, bone morphogenic proteins, and it's an osteogenic scaffold. It can provide immediate structural support, specifically in ACDFs. You can use an anterior iliac crest tricortical strut and essentially obviate the need for a plate. There's no disease transmission. Even the fancy allografts today that are very safe potentially can transmit some kind of pathogen, so autograft definitely doesn't do that. There's very little additional cost to the patient, and it can eliminate the cost and need for instrumentation. Of course, it does, especially in the separate site incision, create wound healing problems, potentially in pain. As much as 25% of patients reported chronic pain after iliac crest donor in ACDFs. Another study showed increased operative time and increased rate of blood transfusion when using autograft compared to allograft in cervical and lumbar fusions. So my practice has evolved from using iliac crest bone standalone to using interbody cages packed with cancellous allograft, except for, as been mentioned, Aetna cases which don't allow peak for 1 or 2 level ACDFs. I use bone marrow aspirated from the vertebral body to hydrate the allograft, and I use anterior plate and screw instrumentation. Posteriorly, I was trained to use separate incision, cortical strips, and cancellous bone, and began evolving away from that using essentially just bone marrow harvested through a jam-sheeting needle from the posterior iliac crest. And in summary, so we can get to the questions and comments, I think autograft is probably the best material available. However, the donor site morbidity and the quality of the allograft options make it sort of unnecessary to make a separate incision. And I think you should use locally obtained autograft whenever available, including the laminar bone or bone marrow from the vertebral body or the crest. Thank you.